A 16-year-old polytrauma patient arrives in your emergency department in severe hemorrhagic shock, exactly 1 hour after a high-speed bicycle accident. 2 beds down, a 4-year-old presents with primary post-tonsillectomy bleeding. She is awake and highly anxious, with fresh blood actively oozing into her airway. In the fast-track area, a 7-year-old sits with refractory epistaxis. The bleeding persists despite 15 minutes of direct pressure and intranasal vasoconstrictors. These 3 cases represent distinct hemorrhagic profiles, yet they all share a potential solution. Tranexamic acid, or TXA, is a low-cost, shelf-stable medication that retains its activity even through the temperature fluctuations of a pre-hospital environment. Despite its versatility, TXA remains underutilized in pediatric emergency departments. Clinicians often hesitate to deploy it due to reliance on adult-skewed data, a fear of inducing thromboembolic events, and unfamiliarity with non-intravenous formulations. To utilize this tool properly, we have to look closely at its molecular mechanism. Doing so allows us to map distinct pediatric bleeding presentations directly to precise, route-specific protocols. Returning to our 16-year-old polytrauma patient, survival here depends on immediate systemic hemorrhage control. In these moments, emergency physicians sometimes withhold systemic TXA based on a specific misconception. They fear it acts as a procoagulant that will trigger deep vein thrombosis or stroke. To see why that fear is misplaced, look at normal hemostasis. Fibrin weaves into a web, trapping red blood cells. Simultaneously, plasminogen converts to plasmin, degrading the web. TXA binds to plasminogen, blocking it from fibrin, halting the cleavage of the web. TXA does not generate new blood clots. It is an antifibrinolytic. It locks the existing clots in place and prevents them from degrading too early. The clinical data reflects this mechanism. The CRASH-2 trial studied over 20,000 trauma patients and found no significant increase in vascular occlusive events among those treated with TXA. Pediatric data corroborates this safety profile. The Pediatrics trial evaluated severely injured children in military combat settings. The researchers found that TXA administration was independently associated with decreased mortality, with no increased risk of thromboembolic complications. The mortality benefit of systemic TXA is strictly dependent on timing. It must be administered within 1 to 3 hours of injury. Because coagulopathy shifts dynamically, delivering TXA after that 3-hour mark actually increases the risk of death from bleeding. For systemic pediatric trauma within that window, the standard regimen is a 15 mg per kilogram IV loading dose given over 10 minutes, followed by a 2 mg per kilogram per hour continuous infusion. In pediatric polytrauma, the primary clinical concern is not whether TXA will cause a clot. The concern is whether the emergency team can execute the systemic dosing protocol before the critical 3-hour window closes. Our second patient is the 4-year-old with primary post-tonsillectomy bleeding. She is awake, alert, and actively bleeding into her pharynx. Attempting to gain IV access in an actively bleeding, highly anxious toddler often induces crying and spiking blood pressure, which exacerbates the hemorrhage. Meanwhile, the standard fallback of gargling ice water poses a serious choking risk for a child this age. We can safely bypass those hazards by utilizing a standard respiratory nebulizer to deliver TXA via mucosal absorption. Nebulization delivers an immediate, high concentration of the antifibrinolytic directly to the bleeding site. Because it acts locally, systemic absorption is negligible. The literature supports this route. Nebulized TXA has successfully temporized not only post-tonsillectomy bleeding, but also severe lower airway hemorrhage, including diffuse alveolar hemorrhage in critical care settings. Preparation requires no specialized equipment. Pour the standard 100 mg per milliliter IV solution directly into a respiratory nebulizer chamber. Dosing relies on a weight-based binary. Patients under 25 kilograms receive 250 milligrams, and those 25 kilograms and over receive 500 milligrams. Utilizing nebulized TXA allows the clinician to manage a high-stress hemorrhage as a straightforward respiratory treatment, completely bypassing the bottleneck of IV access. Finally, we have the 7-year-old patient with refractory epistaxis bleeding from the Kiesel-Bulk plexus, completely unresponsive to direct pressure. Traditional secondary interventions, like invasive nasal packing or silver nitrate cautery, are painful and poorly tolerated by conscious children. Topical TXA serves as a painless frontline alternative for mucosal and gingival bleeding. For epistaxis, the standard IV solution can be repurposed directly. 5 milliliters, which equates to 500 milligrams, can be applied to a cotton pledget and inserted into the nair, or sprayed directly onto the mucosa using a medical atomizer. This strategy extends to oral injuries. For gingival trauma or frenulum tears, the standard oral tablet can be repurposed. To make a hemostatic paste, crush a 650 milligram TXA tablet into a fine powder and mix with a small volume of sterile saline. These cases demonstrate that TXA is a stable and cost-effective tool. It provides immediate hemostasis for everything from minor mucosal injuries to massive systemic trauma. Map the hemorrhage presentation to its optimal delivery route. Systemic trauma requires IV administration. Airway bleeding responds to nebulization. Mucosal bleeding requires topical application. If using the systemic trauma pathway, the 3-hour post-injury window is absolute and non-negotiable. As you integrate these protocols, you can confidently discard the myth that TXA causes thromboembolic events, but you must remain vigilant for its documented side effects. True adverse effects associated with systemic TXA include hypersensitivity reactions and specifically lowering the seizure threshold through the inhibition of GABA A receptors in the brain. Because systemic delivery carries these specific neurological risks, localized administration, like nebulized or topical routes, should be the preferred method whenever clinically appropriate. By adopting these evidence-based protocols, emergency clinicians can safely temporize pediatric bleeding, minimize painful invasive procedures, and optimize outcomes for the most vulnerable patients in the trauma bay.